Okay, so this much to read, hardly anything. So you read it. Whenever you wish to start, I will start the timer. Whenever you wish to start, you can.
Ma'am, I'll start. Hello,
Hmm.
I'm Grishma. So you are?
Yeah, I'm William.
Okay, William, nice to meet you today. I gather that you're like very new to the department. How's it been in the department?
Yeah, I'm doing well. I'm fine.
Okay, I would. It's glad that you are having a wonderful time. I would like you to learn new things, and feel free to ask me anything anytime regarding academic, and I'll be there to help you. So today we are going to learn about closed laparoscopic technique. So William, can you tell me why do you want to learn about this?
Yeah, because I have got an interest in minimal invasive surgery, so I just want to start from the basic.
I appreciate the positive attitude in you because you wanted to learn about the newer techniques and you have approached me. So today I will be briefing you about the laparoscopic techniques, what we follow here, and like the methods of entry, how we use the aids used in it. So you have free to stop me wherever you find difficult to follow. Is it okay, William?
Yes.
Okay, so William, laparoscopy is a method like with minimal access we can do surgery on the patients. So in this, how it makes a difference from laparotomy is that it will help in faster recovery of the patient and less pain relief, and we can do many procedures in a day-care basis. So normally we use mainly one main port and two or three lateral ports. So can you repeat with me how what are the general ports used? How many ports we are using?
Yeah. There will be one primary port for camera, and there would be secondary ports for instrument.
Okay, so this primary port is put in the either in the supraumbilical or infraumbilical portion, and the other two ports can be are, placed in the right or left lumbar or iliac quadrants. I hope you know about the quadrants of the abdomen.
Yeah. You-
Okay, that's very good. So here we are also provided with an instrument called this instrument is called the Veris needle. This instrument helps us in in an easier way of entry. This helps in preventing possible vascular injuries during entry. Am I clear to you, Willem?
Yeah.
Okay, so I'll tell you how this instrument is used. So this is holded. I'll see. I'm showing you. It is like in a pen holding manner, and we will raise the abdomen, and then we will hold this in a pen holding manner and apply it perpendicular. So how will you apply it?
Perpendicular.
Yes, wonderful. At right angles, and once it how and we have to make sure before that it has entered the peritoneal cavity before. There are many tests to uh, to verify that the varus needle is inside the abdomen. First, we can do a saline test, drop test. So we can put a drop over the needle and we can look for the movements and free flow of saline into the abdomen, and also by connecting the pressure check we can understand. So, and then once the we have entered the peritoneal cavity using this varus needle, we can we can insufflate um, air into the cavity. Am I clear, William?
Yeah. So what is the rate of it?
Yeah.
And if there
So,
is needle fail, then what to do?
sorry, I didn't get understand you, William.
Yeah, if any difficulty we are unable to do, how many times we can use various needle for entry?
Sorry, actually, I, I don't. I'll just refer it and tell you. But whenever you face a difficulty in accessing, there are other methods to enter laparoscopy. That is called the Hassan's method, in which we put an incision in the tumbical incision, and we create open laparotomic wound, and then use the trocar to enter. And also, if at all there is additions in the patients, we can follow a entry called the Palmer's entry, which is in the towards the left side. But for that, we should that is in the left mid clavicular line. Two types of other methods I told you is which, can you repeat after me, William?
Yeah, yeah, it's in Palmer and Hassett.
Okay. And once we have created the pneumoperitoneum, we can use the primary port to enter into the cavity. So there is a pressure for entry into the cavity to decrease the injury to the vessels. That is around 20 millimeter of mercury. So what is the pressure for entry into the putting ports into the abdomen?
Yeah, 20.
Okay, once we put the primary port, we can connect the camera and visualize the abdomen, and then we can proceed with the lateral ports. Normally, some surgeons use 1 to 2 lateral ports. So we do it. So the problem in putting lateral ports is we have to prevent injury to a major vessel called the major vessel, that is the inferior epigastric artery. So which vessel we have to be careful?
What are the vessels at risk, and how we can take care of them, how to avoid the injury?
Yeah, we should. So it is the inferior epigastric artery. This is the main vessel which can be injured by putting lateral ports. So we have to do it under vision, like we have to illuminate using the camera scope, and we have to proceed with the non-vascular area. We should avoid the vascular area, and if we put ports, then we will be able to avoid the vessel. So we have to better illuminate it using the camera scope, endoscope, and then we have to put the ports. And if at all there is an inadvertent injury, normally if it is a small injury, it can stop by itself. If it is not stopping, we can use a Foley's bulb or cautery to stop the bleeding. Am I clear, William?
Yeah, yeah.
And one more thing is the operating pressure for in laparoscopy is around, even though the pressure at which we introduce all the scopes are around 12 to 20 millimeter of mercury, we do the procedure around 12 to 15 millimeter of mercury. So that can you repeat with me the pressure?
12 to 14.
Okay, so there are few complications anticipated, like injury to the vascular injury, then bowel injury. That is more if there is a risk of additions, like if there is a history of previous surgery. So all these histories should be elicited further, and also there is anesthesia related complications. So William, I gather you could get a brief about close laparoscopic technique. I will be giving you video links and strata videos for you to refer, and you can come back to me anytime. And also, you can attend cases if possible, so that you have a practical idea about the laparoscopic techniques. So it was a great session with you, William. Thank you.
Okay. 20 seconds left.
Ma'am, I remember only this much. I didn't prepare where this needle have to go.
Ah. Okay, so well done. But there are a few points that has to be highlighted that you didn't do highlighting of the point that I will speak about that. Okay. Rest you did fine only. So this like this way you have to do. You have to do your hello William, how are you doing today? I can see that glad to see you today here. I can see that you have learned to know about the safe laparoscopic entry technique. It is a very nice topic you have chosen. But can you tell me the why you have chosen this topic? Okay, have you got any idea? Have you ever assisted or seen some video? Okay, and how long are you with us? Do you feel supported? Okay, so apart from this, like in today's session, William, I'm going to explain you, about the pre-op checks, various needle, how to check it, about the position of the patient, then how to put the various needle, and how to check whether it is in the abdomen, a bit about the second report. Then, and if I'm not clear at any stage, you can stop me. Okay, so now then this points you have to do now how to do that. So first of all, we have to start with the pre-operative checks. So first of all, light source should be fully functional, attached to the camera, and the white balance is done. Various needle check is done, and we need to make it sure that the cautery plate or the diathermy plate is arrested. So these are the pre-operative checks. So can you tell me one pre-operative check? Yeah, very nice. After that, the second step would be, very important part. Before we do the close entry, the close entry has to be done by the various needle. We have to check the various needle. So in the exam, they will give you various needle, and this is the lock of the various needle. So you can move it, and if it is up, then that means the gas flow could be there. So tap should be open, and you have to do the check of it that the free flow of gas is there. Apart from this, in this, yeah, you will find the spring also. So you will be able to see the spring action and it do have, there are two parts. Inner part is there and the outer. So this is the inner stellate. You get, this is blunt, you can see this tip, that this is blunt, and here there is a vent is there for the air, and this part is usually, this is the sharp end. So there are two tubes. Outer end is the with the sharp edge, and this is the stylet. This is the inner stylet. So before you insert the needle, either it has to be a new needle. If it is a new needle, then it will be fine. But if it is a reusable needle, you have to check for the spring action, and also you have to make it sure that is tap is on and the free flow of gas is there. So same thing I have explained here. So it consists of sharp spring loaded outer sheath. So this is the outer sheath, this is sharp and spring loaded, and inner sheath is blunt. So this is blunt and with a gas channel. Okay, so like if they are giving varus needle, at least about the varus needle checks you have to say. So varus needle has to be sharp. It should be tested for the spring action. We can attach this to the insufflator. Like you can see that he has attached to the insufflator, and you have to see that there should be a free flow of gas has to be there. So this is the major. This is safety. Without checking for the various needle, you can't start with the procedure. So you have to tell this to your junior, and if they have given you various needle as a prop, so yeah, they expect you that you will explain this to the junior colleague. Okay, So this is so check the Veris needle for free flow of gas and also for the spring action. So these checks has to be done for the Veris needle. Then next part, you have to start with the incision. Now safety before incision, we have to make it sure that there should be no palpable intra-abdominal masses and also position of aorta before insertion. So this is from your green top guideline only, this line, but yes, they would expect this, that the safe another safety before once the machine check needle check is done, so next step would be putting incision, and before that we need to palpate the abdomen to find out any scar is there, any mass is there, and the position of aorta before the varus needle. And it would be very important that as we are going for abdominals gynecological surgery, so bladder has to be empty. Now then you have to speak about the incision. If they have given as a prop for the incision, then you have to speak about incision. It is vertical from the base of umbilicus, so it is vertical incision from the base of umbilicus, and not the skin below umbilicus. So the base of umbilicus, it has to be the vertical incision. And again, safety, this safety point you have to keep on speaking to your junior colleague. This is going to give you marks, okay? So the another safety here, we should not incise so deep so that it directly enter the peritoneal cavity. So it is a superficial incision only, okay? So there are two three safety points here that you have to speak. After that, what you will say, now the incision is done, so we have to holding of the varus needle. So varus needle is held in a pen shaped manner or in a pencil holding manner, and usually you will hold from tip at least 3-4 centimeter, or because only this much is to go. So you will hold it pen holding manner, and a little below, so only like from tip 3-4 centimeter above you will hold it, okay? And after the putting it, you will stabilize the abdominal wall. So so this also you have to tell the junior, that will hold it in a pen shaped manner, and the lower abdominal wall has to be stabilized, and it is put 90-degree angle to the skin, and it be pushed only that much, so that it can penetrate fascia and peritoneum. So we would hear two clicks, and the two clicks for fascia and and the peritoneum, so two clicks will be there. So these are these are the basic thing that you have to tell to the junior. And because you can understand, they're asking you about various needle entry. Apart from this, they are you are teaching your colleague, and you have got guideline also. So each and every part of the safety you have to highlight here, okay? So there would be two clicks, like, and all of you guys, you go to your departments and just practice this once, how you will hold in, though it is a only 5-second job, how you will hold it and how you will insert it. Just take some paper and do in that. After that, another safety here, William. So once the varus needle is inserted, it should not be excessive movement. It should not be allowed. Why? Because if it is in the bowel or vessel, then it will make the complex tear or complex injury. And if the two we can do it for 2 times. If it is failed after doing 2 attempts of various needle, consideration for alternative approach, either open or Hessian technique, or a Palmer point entry to be done. So this was the question I was asking you. So these are the safety things. Every part you have to explain it to the junior colleague. Now, once the varus needle is in, another safety that we have to do the checks whether the varus needle is in the abdomen or not. So there are two type of tests are there. The one is Palmer's test, another is insufflation test. Now this is the Palmer's test. So what you will do, you will take a syringe filled with a normal saline, and you will apply it over the needle. Now, if you and try aspirating it, that if you aspirate it, and usually if it is in the abdomen, you will not be able to aspirate anything. But if it is in any vessel, you will there would be blood, and if it is in the bowel, there will be bowel content. So after that, so this is the first part where when you are trying to aspirate it. After that, you will flush the fluid. So when you flush the fluid in, and if it is in the abdominal cavity, the fluid will go into the abdominal cavity, and if you again try to aspirate it, nothing will come out. Nothing will come out. And if it is not in the abdominal cavity, if it is in the intra-abdominal structure, omentum, bowel, or adhesion, in that situation, whatever the fluid you have flushed, it will come out back. Okay. So this test is Palmer's test. That first, you would you will attach the 10 ml syringe with the NS. We'll try to aspirate it. So if it is intra-abdominal, nothing will come out. Then after that, you flush it with the normal saline. After that, you again aspirate it. If it is in the abdominal cavity, nothing will come out, because with the negative pressure of the abdominal cavity, whatever the fluid it is there, it will be already sucked in. So this is the Palmer test, and you guys might have seen this surgery, and every time whosoever even the senior surgeon is doing it, they always do Palmer test. Okay. So it is important test to find out whether the needle is intra-abdominal or not. Second test is insufflation test. Like when the varus needle is inserted, we attach the varus needle to the carbon dioxide insufflator. The insufflator machine has got a pressure reading. So if the pressure reading is less than 8, if it is less than 8, then that is another confirmatory test that yes, we are intra-abdominal. So these are the two tests that help in identify whether whether the needle is placed correctly in the intra-abdominal or not. So that you should tell to the your role player. Okay. After that, now the needle insertion. Now the needle, this is the carbon insufflator tubing. Okay. After it is confirmed that the varus needle is placed, then you will do the pressure setting to high pressure, 20 to 25 millimeter of mercury, because high pressure entry is recommended by the Royal College guideline, because this decreases the chances of injury, as the air bubble for the insertion would be high. After, so this is high pressure is now you can see the pressure is achieved here. So after that, what they will do, they will remove this varus needle. They will remove the varus needle, and they will enlarge the skin incision. Why they are enlarging? Because they have to put the primary port. Now this is the primary port. You might have seen that this is the primary port. So this is the this is the trocar with cannula. Okay. This will be inserted here. You already know that. After that, primary trocar insertion, again there is a safety. It should be inserted in a controlled manner, 90-degree to the skin. So you have to speak these terms. It has to be done after stabilizing the abdominal wall in the controlled manner, 90-degree to the skin. And once the trocar is in the cavity, you have to immediately stop. Okay. So this is the primary trocar entry. After primary trocar entry is done, as recommended by the Royal College guideline, you will insert the camera, and there would be 360-degree check. So the surgeon, he is checking from here, and he is checking from here. Why they are doing 360-degree check? Because to find out any bleeding is there, or any bowel injury is there, or any retroperitoneal hematoma is there. And if they suspect that there had been any injury, so they will insert another port, 5 port. They will put the small camera from there, and after that they will again visualize everything again to find out whether there had been injuries there or not. So this is the 360-degree check that is recommended by the guideline. After that, so these are the till that the primary trocar insertion is done. After primary trocar insertion, secondary trocar insertion has to be done. Now secondary is trocar, it could be 10 mm or it could be 5 mm. Usually it depends upon what the surgeon wants. So secondary trocar, now the safety inserting secondary trocar, so it has to be inserted under direct vision. So you can see that this is the camera, and the surgeon is looking at it from inside, and then they are making incision. Okay, so this is the direct they are inserting the secondary port in the direct vision. And yes, it has to be high pressure was we already achieved the high pressure. Now after the port is inserted, it is angled toward the pelvis. Once you visualize the tip, you have to angle it towards the towards the pelvis until the sharp tip has been removed, because there could be injury. So these are the few buzzwords that you have to use in your answer, whether it is a viva station or whether it is a teaching station, because this station comes both way. Laparoscopic viva station, it comes every alternate exam, and teaching station can also come because the exam has become online, offline. Now there are certain checks. What are the injuries that can be done at the time of insertion of secondary port? There could be superficial vascular injury. Superficial vascular injury could be superficial circumflex iliac artery and superficial epigastric iliac artery. So, how to find out that? So, these arteries are superficial. If you do trans-illumination test, like this surgeon is doing, so you'll be able to find out this vessel. You have to put the trocar at the place where these vessels are not there. Now, another part is that is very important is the deep vessel that can be injured. This is if inferior epigastric artery and vein. Now, this can be done from the anatomical landmark. So what is the anatomical landmark? You, when you go inside, you have to look at this. So this is the median umbilical fold. This is median umbilical fold, and these are the median umbilical fold, medial umbilical fold. So artery lies like lateral to medial artery lie this inferior epigastric artery. It passes this umbilical fold. This is the medial umbilical fold. It passes medial to the artery. So here will be somewhere the artery, because this fold is medial. So here will be the artery. So whenever you put a trocar, you have to put lateral to it. So if here is the artery, you have to put trocar lateral to it. Now you can see it in this picture. So this is the inferior epigastric artery, and they have put trocar lateral to it. So this way you will be able to prevent the injury of inferior epigastric artery. So you have to say this. So superficial the vessels, we can do trans elimination test, and for the to avoid injury to inferior epigastric artery, we have to do the anatomical landmark, and it has to be lateral to the inferior epigastric artery. So this part you can't show in the exam, but you have to tell to the examiner when they are asking in the viva station, or you have to tell your role player also, because all these are the safety point. Your teaching station will depend, how much simple you are making the thing, and how much you are explaining all safety points, because everything that is related to safety has to be explained. So this, whatever I have explained, this is a summary of various needle injury. This is a summary of primary trocar insertion, and this is a summary of secondary trocar insertion, because I have shown you in bits and pieces to make you guys understand. So this is the summary that you should know, the way you will do in your viva stations. Now, a when your surgery is done, you should know the laparoscopic exit technique also. So first we have to remove the secondary ports. So secondary port, the camera is already in. So secondary port will be removed when you are looking them under the camera. So they will be removed in the vision only. So after that, like la- last port that has to come out is the primary port or the camera port. Before you are moving that, so you will open the valve, so that as much as gas that is possible, that will come out. Because if the gases remains inside, that will cause distension, and also it causes trouble to the patient, shoulder tip pain, that you already aware of. So try to expel as much as the gas possible. At the end, very slowly you will take out the camera port with a laparoscope, with a camera, with the camera in. With this technique, you'll be able to minimize the risk of any bowel or omentum stuck in the port. So these are the laparoscopic and exact technique from secondary port and for the primary port. After it is done, then you have to do the wound closure. According to the Royal College guideline, any midline port over 7 mm, or any non-midline over 7 mm, and any midline port over 10 mm would require sheath closure to avoid any port site hernia. So this is laparoscopy exit technique. Now this can also come, that is the like open Hessen technique or modified Hessen technique. Now like if the like we closed entry is done, and if the closed entry 2 attempts of the various needle is done, and if it is failed, so second will be the open technique only. So in the what is done, the incision is made some umbilical. After that, they will make skin incision, and they will make it cut down to the fascia. Now the fascia is open. After that, they will elevate the fascia and incise it. After that, they will apply the stay suture over the fascia under the either the side of incision. So skin is cut, fascia is cut. On the fascia, they are applying stay sutures. Now peritoneum is there. So peritoneum can be entered either by forceps or by incising. Then this is the blunt trocar. You can directly enter this blunt trocar. So in this way, like it is called as an open entry, because you are making a small opening or wound as you do the open surgery. Then blunt ended trocar will be inserted. So there could be no injury, because this you see this is the Hassan trocar. So with this trocar, with this blunt end, you can imagine no injury can happen. After that, you will remove this and you will visualize inside. Then other entry insertion will be done, and we have applied the stay sutures. So these stay sutures usually fix to the trocar, and after the trocar insertion is done, then you will put the camera in. So this is a different way of entering abdomen if you are not doing closed entry or the varus needle entry. Rest secondary port insertion and exit technique, rest part of it will be the same only. Okay, so this is open any one of you have got any question till now in this laparoscopy? So this laparoscopy, whatever I have put here, it can come as a like teaching station. So they will give you they can it can come as like closed open safe laparoscopic entry. It can come as open Hassan entry, or same station can come as Viva stations also. And you have to speak top to bottom everything. Any question, anyone? Any
No, ma'am.
question? Okay. So some tips for the role player station. So role player station always greet, and many of the students, they will forget introducing themselves. Introduce yourself, find out your role, whether you are ST5 or consult, or you are consultant, or who are you, and place of consultation. These are the small things, and but if you do that wrong, examiner will have a clue that you have not read your station well. Then make agenda. It has to be very small agenda. Many of the students, what they will do, they will make like 1.5 minute big agenda. So these big agendas, they are not liked by the role players. So make small simple agenda, and don't keep repeating same words again and again. Please use different set of words. Okay, because the examiners, they don't like that all 40 institutions the students coming and they are using same language for it. Always make eye to eye contact, always show respect and to the patient, be attentive. And if she says I'm a sex worker or I have got so many partners, please don't make any judgmental face, because this kind of station would be like win station we have done today. So this would be an lay examiner station, and they have kept lay examiner only for this, to see that whether your facial expressions are changing or not. So be very careful. Always ensure that you understood the patient problem and concern, like what she wanted. So like in the station number 1, the patient wanted to know about her baby, and also the patient wanted to know that what will be her future plan. So asking in that particular station, though it was a postnatal, but too much details of the patient was not necessary apart from this routine postnatal history. So you have to kind of modify the station and the answer according to whatever they have given, because you can understand that it is only 10 minutes that you have to show your skill. And whatever the diagnosis, make your patient understand, because sometimes the I have seen the student will explain everything and the patient even don't know the diagnosis only. Whenever you are taking history, use a blend of open and closed question, or whatever the clue is patient. If you're not on a right track, so patient would try help you. Patient will give you some clue, either non-verbal, making some faces or something, or she will give you some verbal clue to help you would be given 1 or 2 times. If you are not able to pick, then you will be in a wrong track. Always involve the patient in the management of the patient, of the her care. Respect her autonomy, because the maximum mistake the students they will do, they will decide the treatment for her. So that would be the paternalistic approach, and that will be really not liked. That way affect your communication with the patient, and also lay examiner will mark you hardly. So at the end, if you could summarize and explain the agreed plan, that would be very nice. And always close the station, and always give her chance to come back again. So these are few tips for the role player station. Please don't ignore the concern of role player, and please always make eye to eye contact with the role player. These are the important thing. And please don't make mistake in reading the question. So these are the few things, common things that I have to say for the role player station. Now for the viva station or case based discussion station, like uh, um, you have to look confident. Whatever the tension in whatever the tensed you are, that doesn't make any sense. It is an exam that is checking your confidence, your calmness, how you would manage so difficult situation, keeping your keeping calm. So you should look calm, cool and confident. And many of the students in the case based discussion, they will not look at the face of examiner, they will keep on looking at the on the top of table. Please don't do that, because the communication with colleague is a domain that is tested there. Be confident and make it as a communication with the examiner. Second, many of the students, what they will do in the viva station, what is the information given, they will start the station and they will read the whole information to them. This approach is very too much ignored by the examiner, and they don't like it. Please don't do that. Please don't read the information. Many of the time, examiner will say, I already know the question. Okay. So again, in the exam, questions are not shown. You have to listen to the examiner, and you have to listen to the examiner, and then you have to answer the question. So sometimes whatever the question they are asking, answer will involve 1 or 2 line only. And what the student they will do, they will keep on speaking about that topic. Please don't do that, because their questions are very very scientifically planned. And if the answer to question involves 2 3 lines only, then it is fine, speak that much only. Too much detail, don't speak so much. Okay. And apart from this, it has to be organized approach. And sometimes the students, what they will read the values, hemoglobin is 7, potassium is low, potassium is 3.2. So please don't do that for the exam in front of the examiner knows the value. So you have, they are looking interpretation. So you can say, I can see the woman is, the patient is anemic, I can see she is having hyperkalemia or hypokalemia. So do that. And apart from this, whenever you manage the patient, uh, it is not whole guideline recitation they want from you. You have maybe from one guideline 2 or 3 lines you would be using, but that much is the knowledge that is required. So you have to manage patient according to the you have to do give the management plan that pertains or related to the scenario they are asking. So that part of guideline they are looking for from you in the applied knowledge. It is not whole guideline that you have to revise. Okay, so apart from this, in the I have seen in the Viva stations, like the students, they are very panicked. They keep on tapping their table or their legs or something like that. So these are the involuntary behaviors. They are not liked by the examiner. So do the exam with confidence, with the open approach, and don't make any any unintentional movements that is not liked by the examiner. So that's all for it. With that, with apart from this, sometime you will get total surprise station. So if you get total surprise station, then also, just take deep breath, read the station 2 times. You'll be able to identify the template, the module. So do general and follow your module. At least you will still clear information gathering, communication, and patient safety. If you don't know a topic, only one domain will be borderline, that will apply knowledge. So either they will make you pass or they will make you borderline. But many of the students, when they see surprise station, they will be panicked. So please don't panic, you know so be calm. It is just an exam. Be natural in the exam, because they don't want parrots, or that you are reciting something. You have to behave very naturally, and you have to do this exam as if uh, uh, as if you are doing 14 patient all together. So don't mimic anything, and just be natural and just be confident. That's all I have to say. Will this with this any one of you have got any question? Any one of you have got any question?
Sorry, hello, doctor.
Yes.
Doctor, if it is a new station and we don't have any applied knowledge in this to go, so what we need to do in this situation?
See, you are practicing obstetrics and gynae for very long time. All of you have done your post graduations. So,
Hmm.
total out of the blue will never come. It will come something that you have got less knowledge. So say whatever you know, or just keep on saying general things. Take general
Okay,
history, speak about the examination, just say general advice to the patient, give some reading material or this. So do the station generally. In that situation, your information gathering, communication, and some part of the patient safety, you will still pass. But don't panic. Don't panic, because
okay,
in your clinics also, whenever you do the station, like whenever you see patient in your clinic, all problems you never know. So sometime you will get a patient and you are unable to get the diagnosis. It is
yes,
fine.
true,
We
yes,
manage
yes,
them generally, and we just say, okay, next time after investigation we'll see and meet again. After that, we just read or call some colleague, and discuss the case, and next time we manage the patient. And so behave the way you will do in your clinics. Exam is just
okay,
your clinics. Okay.
yes,
but the
yes.
people
Thank
get
you, doctor.
very people get very panicked. So that panic should not come.
Okay, okay. Thank you, doctor.
That's all. Okay, any other question left? Okay, people. One thing. Okay, about the cystic fibrosis, I have to say, someone was asking free fetal DNA. So free fetal DNA, it can detect some of the genes, so it will not be the complete confirmatory test. So because of that, whatever the papers I read, all they are speaking about PGT, that is a pre-gamet diagnosis, and all they are speaking about this the CVS amniocentesis, because this would be the definitive test. Pertaining to our scenario, the patient would require complete diagnosis whether the baby is affected or not. So, in my opinion, PGT and invasive testing for the future pregnancy we have to give. This is the one thing I have to add. Second thing, someone was asking about the lifespan. So, like lifespan, it could be some. It is like it is shorter than the usual. So it will be somewhere 37 to 50 years. So no need to quote any number. Just say yeah, it will be sort of a near to the. It will be lesser the lifespan, but with in this era with advances of treatment, most of the people they will have quite good life. So this way you can handle the question. Okay, so thanks for joining. All the best for your exam. All of you come out with the flying colors. Bye, people.
Thank you.
Thank you.
Thank you, ma'am.